At this time, though, I'd like to introduce our keynote speakers, Dr. Ibni Ali, Dr. Jennifer Cope, Dr. Alejandro Jordan Villegas, and Dr. Humberto Liriano, who will be talking to us about the research as well as clinical care of amoeba. Just a little bio. I know you have some of this information with you, but Dr. Ali is a biologist with the Waterborne Disease Prevention Branch in the National Center for Emerging and Zoonotic Infectious Diseases, and is the principal investigator of the free-living and intestinal amoebas laboratory. He also oversees the overall diagnostic and research activities of the lab, which studies the free-living amoeba as well as intestinal amoeba. Dr. Cope, from the Centers for Disease Control and Prevention as well as Dr. Ali, is a medical epidemiologist and infectious disease physician with the Waterborne Disease Prevention Branch in the National Center for Emerging and Zoonotic Infectious Diseases. She oversees the Free Living Amoeba program, which supports clinical, epidemiologic, laboratory, and communication activities related to free living amoeba. And then Dr. Jordan Villegas, with the Florida Hospital for Children, is a pediatric infectious disease specialist. And he received his medical degree and immunology training with honors from the Universidad del Valle in Colombia, and completed his pediatric training at Miami Children's Hospital in Miami. His clinical interests include antibiotic stewardship, the study of the host response to different viral pathogens, and also the relationship between these pathogens and bacterial superinfections. And then Dr. Liriano is an addition to the program, and we are privileged to have him join us today. He is a pediatric critical care specialist and will be presenting Sebastian's case along with Dr. Jordan Villegas. He's currently the chair of the Pediatric Critical Care Department at Florida Hospital for Children, and his research and clinical interests are pediatric traumatic brain injury, sepsis, and cardiovascular diseases. So with that, I'd like to bring up Dr. Ali and Dr. Cope. Oh, okay, Dr. Jordan. This is Dr. Jordan Villegas.
So as they say, I'm Alejandro Jordan Villegas. I'm one of the pediatric infectious diseases that's part of the Florida Hospital for Children, and my division is with Dr. Alejandro, was a few minutes ago there, and Dr. Liliana Gutierrez, that actually was the infectious diseases that was the day on call when Sebastian showed up. So I have to definitely, thank Federico, Leham, and Liliana, because, with both of them, I think that I talk to them more than my family, every single day regarding cases. But with Sebastian specifically, I think that we talk every single second during the 3 weeks that he was here. So I think that I saw, Federico more than my family during those three weeks, and he actually helped me to put the slides together as well. So we're going to talk about early recognition and treatment, and I'm going to focus on the case with Sebastian, and then we go over the different medication that we use for treatment, and what is the research behind them, when it has been used, and what we can do, and some questions that still are, to answer regarding the disease and the treatment. All right, so I don't have any disclosures, any financial disclosures. So let's start with the case presentation. So he's a 16-year-old male, completely healthy, that he presents with some, progressive headache that is throbbing, really acute onset for about 2 days prior to presenting to the hospital. He defined as a constant, the talk, back of the hand. He didn't have actually fever, just subjective fever, but not actually fever, no neck pain. He got vomiting just twice, some photophobia, but he didn't have any altered mental status. He was not hallucinating. It basically was just headache. And there was a strong family history of migraine. So at some point we thought maybe it was migraine what he was having, not actually related to any type of infection. They actually live in Fort Lauderdale. They are not from Orlando, and they came just for the parks. And actually, when you talk to the family, they were coming for vacation before starting high school, back to school, just for 1 day. And that's the reason why they were here. So they were at Universal Studios the day before they came to the emergency room. He did spend a lot of time on the outside for about 5 weeks. He was a counselor in a camp helping kids, and in that camp, it was a pond. They were using well water, to wash the hands, the face, do many things. He was in charge of just monitoring the kids, but as well he was in charge of, cleaning the horses, helping with the horses' duties. On admission, and especially after knowing the diagnosis, we asked him several times, Did you went into the pond? Did you submerge yourself into the pond? Did you swim in the pond? And he said, no. I don't like it. I didn't do it. The family said, we're from Puerto Rico. We don't like any dirty water. We just like clear water, so we don't go. So we didn't have that history at that, we didn't have that history at that point, and he denied completely. Now going back after he's at home, and we asked him again, now he said, by the way, I did, swim in the pond. I went multiple times with my friends. So we actually now have a clear exposure of why he presented with the disease. There's a strong family history of migraines, and that basically is he was on no medications, as I said, a completely healthy boy. So this is kind of a mix between the ED physician history when he comes and the history from Dr. Gutierrez, our partner, when he comes to the ICU. So as you said, vitals are really stable, a little bit of hypertension, but you can't say that he was having headaches, and that can give you a little hypertension, but he's completely afebrile, heart rate normal. He looked ill-appearing, but he was non-toxic. And the ED, he didn't have any nuchal rigidity, which is one of the signs for meningitis. When he came to the ICU about 2 hours, he already was having a stiff neck. No rash, a lot of photophobia, but other than that, completely oriented, completely alert, able to speak, was no issues at all. The labs are completely normal, so no elevated white cell count, normal protein, normal differentiation. We don't have the opening pressure that is really important to see if there is an increased pressure in your brain or not documented. But when you look at the white cell count on the CSF, 108 with neutrophils of 62%. When we're a clinician, we said, that's definitely not concerning for bacterial infection. That's more concerning if something for a viral infection. And you look at the glucose normal, protein slightly elevated, but we can say within normal limits. So nothing on that CSF will trigger any kind of alert that this is something really bad going on when you look at the initial CSF that he got. So he presents to the ED at 10:20 in the morning. By 12:20, so 2 hours after an LP is done, by 12 hours, the lab calling saying, I have a suspected anemia. When they take a look at the slide, they call the pathologist. The pathologist come right away to the hospital, verifies the information, say, definitely this is Amoeba. So by 14:27, the Amoeba exam is concurred. Liliana Gutierrez gets a call at 2:50. The ICU as well is consulted. They receive a dose of ceftriaxone because, it's a really common practice in the emergency room. If you're suspecting meningitis, you give ceftriaxone. So it's not that we're thinking the ceftriaxone works for amoeba, but it's kind of a common practice that we do, which in this case probably was a little bit, overdone. But and then by 15:30, he gets his first dose of amphotericin IV, which is an antifungal that has been, documented in many cases of amoeba as one of the medications that we need to use. This is already in the ICU. So by 14:20, hypothermia is ordered. 16:30, he gets his first dose of meltefusine, which is oral medication. He's completely alert. He takes the medication by mouth. He's talking. By 16:50, although he is completely alert-oriented, the decision is made to put on a pentobarbital coma, get intubated, hypothermia is started. He gets his doses of rifampin, fluconazole, azithromycin. That are the other medication that we use in the cocktail. Femoral line is placed, EVD is placed by about 1940. The ICP is 6 to 8, which is extremely normal, so it ranges until about 20. So an ICP of 6 to 8 is completely normal. So he never got any actually signs of increased intracranial pressure, and I think that that's really important for his outcome. And then we do intrathecal amphotericin. So we get the antifungal medication that he received IV, and we put it through the tube that goes to the brain and goes directly to the brain. So by about 48 to 72 hours, the ICU started weaning off the pentobarbital, and then we got a discussion with Dr. Liliano because we said, the CSF is still positive. Are you sure that we want a rewarming? Because the thought about hypothermia is that it's not just decreasing the swelling and decrease the toxicity of the brain. We think, I don't know if it's true or not, but we think that if the amoeba likes to grow on warm and we cool the brain, we may decrease the way that the amoeba kind of reproduces. We don't know if that's actually true or not, but that's kind of one of our beliefs. So I remember talking with Umberto and with Federico. I said, should we rewarming or not? Because this amoeba is still present on the PCR, so are we sure? And then I remember Umberto saying, this is time to do it. If not, we're going to start having problems, with organ failure secondary to the hypothermia, the heart, the kidneys, the liver. So he makes the decision to start rewarming the patient, but he said, we're going to do it really slow, knowing the fashion that usually warming is done. So he gets rewarmed, about 0.5 centigrade every 6 hours. So it took about a day and a half to get to 37 degrees, which is a normal body temperature. Then we start seeing some complications. So the creatinine, which is one of the way that we measure kidney function, start going up. And that's definitely secondary to medication. So amphotericin is one of the main medications that is nephrotoxic, and meltefusine as well in the packet insert is really nephrotoxic. So it's definitely this is probably a combination of medication that is giving us the problems with the creatinine. The ICU team starts saying, this is time to wake him off from the vein and starting to wake him up. But in that, he develops pulmonary edema. They are kind of, suctioning a lot. He developed pulmonary hemorrhage, then he goes back again on a lot of sedation, back into bed, and kind of hold off a little bit. We're trying to wake him up. The creatinine doesn't get better, so hemodialysis gets started. And then, Federico and I start talking, what do we do with the medication? Do we stick to the plan, or do we change the medication? Because now, talking with Humberto, he said, I'm afraid that he may never come back from the kidney function, maybe come back. So he may be alive, but we're going to give him some nephrotoxicity. So we made the decision to hold the amphotericin and see what happens. And at that point, we got some CSF PCR that was negative, so maybe we're fine. And then another sample comes back positive. So, just do it again. We do dialysis. We'll see what happens. So we restart the amphotericin again. He gets extubated. In the meantime, he gets some weird sign that we still cannot explain. The arms get really swelling and red. And we don't have explanation for that. Lasted 24 hours and then resolved. He gets some shaking, hyperreflexia of the lower extremity with clonus, which is a sign of some medullary injury that we still cannot prove because we did an MRI of the spine and it was completely normal. He gets extubated, alert, and we get a text from Dr. Liriano saying he's speaking. And he's bilingual, and he's speaking English and Spanish. So continuing in sedation. By August 22nd, he is talking well, ambulating with assistant, he's texting with the friends. We do the press conference. He goes discharged to rehab on the 26th. He took medications until September 3rd, and he was discharged home on Monday. So just 4 days ago, he's back home. He's starting school this coming Thursday. So this is kind of a picture what we did with the cooling. So he gets admitted on the 7th. Cooling starts. You see the temperature around 93, 94 degrees. But about 72 hours, rewarming starts really, really, really slow. And then until he gets to the temperature, and he started having some fevers. So at the beginning, we started saying maybe he's getting a super infection. We started some antibiotics, but all the cultures were negative, so we decided, just to stop. And probably was just part of the rewarming process and everything that he was going through, but some withdrawal from the medication that we're using for sedation. In this graph here is the intracranial pressure. So as you see, it goes up to 20, and 20 is normal. So he always remained within the normal ICP levels. When you see these high peaks of ICP, it's related when they're putting the amphotericin through the EVD that goes to the brain. They have to clamp that tube for the medication to stay in. And that's the only time that we see some kind of elevated pressure, but it's still within the normal limits. These are the CBCs that we did, pretty much unremarkable, except that we did see a lot of nephrotoxicity with the creatinine going up, which is slowly coming down with no medication. It's kind of getting better. This is kind of the CSF analysis, and I said this is the CSF from presentation. Any clinician that sees this CSF, even if they have infectious diseases training or not, they are going to tell you in the ED, this looks like viral meningitis. I'm not concerned for anything. White cell count is slightly elevated. Glucose is completely normal. The differential is not that elevated. The protein is slightly elevated, but nothing to be worried. So anybody will actually miss a case of amoeba based on that initial CSF on this case. We did see some elevation of the white cell count on the CSF kind of at the end, which attributing to chemical meningitis secondary to the amphotericin, because every time that you put medications in the brain, it will kind of inflame the brain, and that can give you increased white cell count. And this is the PCR, but Dr. Ali is going to talk about more in depth about the PCR testing for the case, and in general, what the testing is. All right. So and he's going to go in detail on that. So we're going to talk about, the final diagnosis was primary amoebic meningoencephalitis due to Naegleria fluoride. Let me see, we're doing good with timing. So as you know, Naegleria, it hides in cysts. So this cyst is not infected when it's kind of cold water. When the water starts warming up, then develops into trophozoites, and the trophozoites is kind of the infectious part of the infectious stage of the amoeba. So it goes into the water. If you're in recreational sports, in water, diving, hot springs, rivers, ponds, lake, unchlorinated pools, then the trophozoite can go up to your nose and goes to the brain, and then you get the encephalitis. So the early symptoms are like they were saying, they can be like any viral infection. They can resemble bacterial infection. They can resemble viral meningitis. They can present with high fever, severe headache, photophobia, nausea, vomiting, seizure, altered mental status. Some of them actually said that they have smells and taste differences, probably because it goes through the olfactory canal when it goes up to to the nose, to the brain. Symptoms progress rapidly. They have severe mental status alterations, seizure, cranial palsies, coma, herniation, and death. So this is the way that we'll look on a slide, and sometimes can be missed with a regular white cell. So if a tech is just goes really fast through the slide or is not really experienced, it will miss and say, this is a regular white cell on the CSF that has maybe an abnormal shape. So you have to be really well trained sometimes to make the differentiation between an amoeba and a regular white cell a regular white cell on your CSF. So we're going to talk about a little bit of the treatment and the medication that we use. So one of the main medications that we use is amphotericin B. There are two types of amphotericin that we use, amphotericin B, which is called deoxycholate, and liposomal amphotericin B. Usually in adults, we use liposomal because it's less nephrotoxic, but specifically for amoeba, the one that is deoxycholate, is a better medication because what we call MIC, which is the amount of medication that you need to kill, in this case the amoeba, for the other one is really high. So you will need extremely high doses of the medication. So in these cases, we use deoxycholate, and that's probably what's going to give the problems with the nephrotoxicity that we saw in this case and probably in other cases. So in this specific paper, what they did is they took the amoeba that was isolated for one of the patients, and they tested about different components that we use to treat meningitis in many cases, like penicillin, chloramphenicol, quinine, metronidazole, that is work for other amoebas really well, but not for this one, and then amphotericin B. So what we're seeing here is kind of the CSF level that you obtain, and this is the minimum inhibitory level of the medication. So it actually inhibits the growth of the amoeba. Azithromycin is another medication that we use, and this paper kind of looks at how the medication works, and it compares amphotericin against azithromycin, which is a medication that you typically will use for community-acquired pneumonia. It's really used for a lot in the outpatient setting. So these are mice that are infected with Naegleria, and on A you will see amphotericin, on B you see azithromycin, and this is days after infection, and this is the percentage of survival, and there are different doses. So this one is mice that didn't receive anything, so they just got placebo, and all of them died for about 16 days after inoculation. And this one is amphotericin at different doses, with the survival rate for the mice is about 50% when you use the high dose. So 50% of them survive, 50% of the mice died. When you use azithromycin in the other case, control, all of them died. And if you use the high dose of azithromycin on the mice model, there is 100% survival. So at least on vitro, on mice studies, on animal studies, we know that azithromycin that works, and it's part of the medication that we use in the cocktail. And at least in the mice model, it seems to have a better activity than amphotericin does. Fluconazole is part of our standard kind of cocktail that is recommended, by the CDC. It was used in the other case of survival. The idea of using fluconazole comes from this case report, where they used fluconazole and the patient survived. When you look actually at the in vitro data, comparing different antifungals, and you compare fluconazole with ketoconazole, with voriconazole, there is another antifungals that we have. Of all of them, actually, fluconazole is the one that has less activity. When you use a ketoconazole and voriconazole, they have more activity than fluco does. The problem is, vori has not been used for any cases of PAN as far as I know, so we don't know we should use it or not. But when you look in the in vitro data, definitely works better than fluconazole, has excellent CNS penetration. Ketoconazole, on the other hand, it works really well in vitro for amoeba. Unfortunately, it does not penetrate CNS, and is extremely hepatotoxic. So we tend not to use it systemically unless we have to. But one of the questions is, should we continue using fluconazole? So we should switch to voriconazole, which is is used all the time in pediatrics, in adults. It's a safety medication, penetrates extremely well the CNS, and at least in vitro has better activity than fluco does, but has not been used. So what we have is just case reports of patients that have survived, and the cocktail of the medication includes fluconazole, and that's what we are being using. Chlorpromazine is actually medication that is used for antipsychotic medication, but for some reason does have activity against Naegleria. And I remember Federico a few years ago tried to use it in one of the patients that unfortunately she passed away. We didn't have time to use it, but we were thinking about it when we were reading the paper. Should we start it? Because in vitro, the chlorpromazine does have survival about 75% when you compare with amphotericin, and even when you compare with meltafusine, in mice studies has better survival. But it's less potent. We don't know if actually achieve the CNS or not. We don't have information for that. Now, meltafusine has been recently kind of adapted to be part of the cocktail. We discussed within us a lot whether or not this is kind of the miracle medication or not. And we don't think. We think there is a combination of ICU, hypothermia, pentobarbital coma, early treatment, and the combination of all the treatments together. We really don't think that is the medication alone will have a great impact if you don't do the rest of the things together, the rest of the medication, and the rest of the ICU support that we give. But definitely it does have good in vitro activity. As I showed you before, has about, in mice study, about 75% survival rate. Was used successfully in what's kind of Balamuthia, which is another free-living amoeba. In the past was able to get through the CDC. Now it's commercially available because it was granted FDA approval for the use of Leishmania. So still for using for amoeba is an off-label use because the approval is for Leishmania, it's not for amoeba. And it happens to be that the headquarters of the medications are in Orlando, and that actually was really helpful to get the medication on time. Corifungin is another macrolide. It's another medication. It's water soluble. Has in studies, which is just unfortunately in mice and in vitro, has again 100% survival rate compared with amphotericin or compared with the control. So it looks like a promising medication. It was granted by the FDA the description of an orphan drug, but there is no in vivo data. So we don't know what is the dose in humans. We don't know if it's safe in humans or not to start using. And actually, I think when I look at the FDA webpage, in 2011 actually was granted the designation as an orphan drug. It's not approved. And the last paper was this one. So I'm not sure exactly how much other research has been doing with corifungin, but it still definitely has excellent activity against Naegleria, and maybe in the future may become one of the medications that we may use in part of the cocktail. So this is the regimen that now is recommended by the CDC, and is the regimen that we actually follow. So we give amphotericin B IV, amphotericin B intrathecal, azithromycin, fluconazole, rifampin, meltefusine, dexamethasone, plus all the ICU support, including hypothermia, pentobarbital coma, and intense ICP monitoring. There is a lot of questions still to be answered. Who gets sick? As so many exposures happen in a given day in fresh water. Why some kids or some adults get sick, what others don't get sick. You may have different kids at the same time in the same area and just one of them gets sick. So is there any type of immunological disorder in a specific patient, any anatomical disorder that help them to get the disease? Are there different virulent strains of amoeba? Maybe ones of them are not stronger than others to cause disease. What factors influence survival? We're pretty convinced that early detection and early treatment does affect survival. We're convinced that in the case that we had a couple of weeks ago was the early detection. He presented really quick with symptoms to the hospital. We think that the inoculum that he got was really low and that helped. If you see, he never presented not even with increased intracranial pressure. So definitely we think that those factors influence survival, having the ICU available, all the ICU support, and all the medications together. What is the optimal antiviral regimen? We still don't know. We use all this medication based on case reports. Maybe there are other medications that will be more active. As I said, I'm still, after reading, I don't know if we should start using voriconazole instead of the fluconazole because the in vitro data show that it's more potent than fluco is. What is the optimal route? I think that up to now, we're going to have to continue using intrathecal, IV medication, and oral medications. And definitely, I think that we need to continue doing hypothermia, putting EVD and ICP monitoring, multiple medications, and aggressive corticosteroid therapy.